Hello, my name is Dr. James Song. I'm a dermatologist at Frontier Dermatology and I practice in Mill Creek, Washington. And I'm coming to you live from beautiful Scottsdale, Arizona at the 2024 Elevate meeting. And I had the opportunity to talk about AD therapeutics, what's new with the topicals and the systemic agents. And this could easily be a talk for an entire day, so I'm going to just try to give you a couple highlights here. So let's start off with the biologics. We have lebrikizumab. This is now our third FDA-approved biologic for moderate to severe AD, and this works on a similar pathway as our two other biologics, so it's going to inhibit IL-13 signaling. Now compared to dupilumab, which is an IL-4 receptor blocker, this is a cytokine blocker like tralokinumab. However, the epitope that this drug works on is different than tralokinumab in that it still allows for the decoy receptor to bind to IL-13 and lower those levels, whereas with tralokinumab it blocks the decoy receptor. So that's one of the mechanistic differences. We also talked about the binding affinity and the dissociation rate, how much tighter lebrikizumab binds to tralokinumab, but how much longer it stays on the target as well, and that may have some implications as far as efficacy. Now, overall, from an efficacy standpoint, very, very good with lebrikizumab. Probably the one thing that stands out, though, is the durability of this drug. And people who take lebrikizumab, we're seeing long periods of patients who stay clear or almost clear. And that was true even if you stop lebrikizumab at 16 weeks, still about half of these patients were staying clear or almost clear at that 52-week mark. From a safety standpoint, quite good, very similar to the other biologics. We're seeing a little bit more conjunctivitis, but overall a very well-tolerated medication with just one dose every 4 weeks during the maintenance phase. The second drug that we talked about was nemolizumab. This is an IL-31 receptor antagonist, already approved for prurigo nodularis in adults, but this has been studied in AD as well. And the data is actually very exciting. As you can imagine, it works extraordinarily fast and it has a really good depth of response for the itch. Even in a matter of a day, we're seeing numerical separation from those itch scores. But from a skin clearance standpoint as well, quite good. And it really didn't matter what your baseline itch score was. Whether you had very, very high itch levels at baseline or whether it was kind of moderate, these patients seem to respond just about the same. So you don't have to think about nemolizumab only as an itch drug per se. And from a dosing standpoint, this is actually our first biologic that's dosed every 4 weeks from the very beginning, so that might be an advantage of nemolizumab. And from a safety standpoint, it's actually quite clean. We're not seeing conjunctivitis, we're not seeing herpetic infections, and interestingly, we didn't see injection site reactions show up as one of the most common adverse events, which is pretty unique with this drug because most of our biologics, injection site reactions are a thing, and that may be due to the unique delivery mechanism that nemolizumab has. Next, we talk very briefly about these extended half-life biologics, and so we have one called APG-777. This is an IL-13 inhibitor that shares an epitope with lebrikizumab, but thanks to a triple amino acid substitution in the FC portion, it really extends the half-life of this drug 3 to 4 times of lebrikizumab. What's the advantage there? Well, you could potentially dose these patients every 3 months with an IL-13 inhibitor. So I think all being equal, less injections probably better, so that's really exciting. And we also have these bispecific antibodies. We briefly mentioned them, where you have one drug that can inhibit 2 different targets at the same time, and there may be some type of additive or synergistic effects of inhibiting, let's say, IL-4 along with IL-31. Moving on to the next topic, we mentioned the OX40 pathway. So this is a novel pathway for us in dermatology. So OX40 and OX40 ligand, we consider these to be co-stimulatory checkpoint molecules. And so when they come together, they're responsible for activating and causing expansion of these T cells, particularly effector T cells and effector memory T cells. Now we know that OX40 is overexpressed in patients who have atopic dermatitis, but the OX40 is actually only seen in these effector memory T cells and just the regular effector T cells. Why is that important? Well, because this is not seen in naive T cells or resting memory T cells, and so we're not getting like this generalized immunosuppression. We're just targeting these particular T cells that are pathogenic, and because it targets these memory T cells, you are getting a potential of having long-lasting effects even after you stop the drug, right? So this is potentially disease-modifying. And the T cell subsets that are also affected is not just Th2, it's also Th1, Th17, and Th22. And this could be relevant for us in AD because we know atopic derm is a much more heterogeneous disorder than just, let's say, psoriasis, where we have a lot of different immune accesses that are at play here. So you can maybe treat a broader range of AD patients with this type of mechanism. And we have two drugs in this class. We have amlitelimab. This is an OX40 ligand inhibitor, which is found in antigen-presenting cells. And then we have rocatinlimab, which is an OX40 receptor blocker found primarily on T cells. And moving on here to the topicals, there's a lot going on here as well. We're going to start with topical ruxolitinib 1.5% cream. This is a JAK1/2 inhibitor that's already approved for mild to moderate atopic dermatitis in patients that are 12 and up. And just to kind of summarize what we talked about is it has very, very high levels of efficacy. I would say objectively, these are the highest numbers we've seen. Over half the patients are getting to a clear or almost clear, and it happens very, very quickly. Okay? And then from a pediatric population now, we have data going down to the age of 2. Currently not FDA approved for this age, but hopefully we're going to get this sometime next year. But the efficacy pretty much mirrored what we saw with the adult patients. Over half of these patients getting to clear or almost clear. A safety profile that is quite reassuring, really not seeing any signals when it comes to those adverse events of interest that the box warning speaks to. And we're seeing very low systemic absorption of this drug if you are using it per the label, which is twice a day, up to 8 weeks continuously, and then kind of use it on an as-needed basis. Now, if you stay in the JAK class, we have another topical that's going to be hopefully coming to us in the next year. This is delgocitinib. This is a pan-JAK inhibitor. Comes as a cream vehicle twice a day. It is actually approved for chronic hand eczema in Europe earlier this year, and it's based on 2 pivotal studies looking at chronic hand eczema patients compared to a vehicle. And when we looked at various different measures, whether it was a clear or almost clear, or a 90% improvement in the HEC score, we saw that it outperformed the vehicle, which is very exciting because, look, a lot of our hand eczema patients, they're very afraid of using topical steroids. They're worried that it's going to cause side effects, they're poorly adherent with it. So having a non-steroidal option in delgocitinib is very exciting. And the last thing I would mention is that there was a head-to-head study we talked about where we had an oral retinoid called alitretinoin, not something we use in the US, but in Europe, this is kind of the first-line systemic agent for chronic hand eczema. And in a head-to-head study, we actually saw delgocitinib. Not only did it work more quickly, but overall just a better efficacy even through 24 weeks. The next topic here is going to be roflumilast 0.15% cream. We consider this to be a second generation PDE4 inhibitor because it has much higher binding affinity for PDE4, up to 300 times greater than we see with some of our other PDE4s in dermatology. Also, the vehicle here is really kind of the secret sauce. We found that this is one of the best kind of tolerated and really just a cosmetically elegant vehicle. And what you'll see is actually even in the vehicle arm in their studies, it's actually quite high because this vehicle has a great way of moisturizing and repairing the skin. And this is currently approved down to the age of 6 and up. And in their study design, it was actually kind of unique in that after 4 weeks, if you got to clear, these patients were instructed to go twice a week, kind of as their proactive maintenance therapy. We haven't really seen that done in a clinical trial, but this is very, very much what we are actually doing in clinical practice. So I think this is giving us more real-world experience with this drug. And what we saw over the course of a year is that the median time for someone to stay clear or almost clear was about 3/4 of the year. So we're seeing very, very good control over the long run with this drug. And this is already approved for 6 and up. 2 to 5 is being studied right now. And lastly, let's talk about tapinarof, 1% cream, already approved for psoriasis. This is a aryl hydrocarbon receptor agonist, so kind of a unique mechanism here. Not FDA approved quite yet. We're hoping that we're going to get this approved sometime next year. But a couple of things I just wanted to point out here. First, this was studied down to the age of 2, right? So if this gets approved, right, this would be the youngest indication that we have out of those 4 drugs that we just talked about. The entry criteria was actually moderate disease. You had to have at least an IGA of 3, which is different from our other studies where it was mild to moderate. And lastly, the body surface area limit was 35%. So that's actually a higher body surface area exclusion than we've seen with some of the other studies. And so we are enriching for a more, I would say, moderate population. And at the end point, we saw actually very good response. At the clear or almost clear, over 40% of these patients are getting there with a very nice delta. But perhaps the most interesting thing about this drug, if you're familiar with the psoriasis data, is that in people who stopped the drug after they got clear, it still took quite some time for those patients to flare. We're talking almost 80 days was the mean time for someone to take before they start to lose that clearance. And so there's a lot going on in the AD space. I think it's exciting because the reality is, even though we've made tons of advancements in this area, there's still a lot of work to do.